Next, a phase 2/3 trial was conducted to assess the efficiency and safety of ibrutinib therapy in patients with age between 18 to 65 years who had histologically confirmed astrocytoma IDH mutant World Health Organization grade 4 or glioblastoma with low-grade glioma history. Most patients were tested IDH mutation status by IHC. Other key inclusion criteria included ZM positive, a key PS of at least 60, previous treatment with radiotherapy and/or temozolomide. The control group was temozolomide, dose-dense regimen, or cisplatin combined with etoposide. The stratification factor was key PS scores. The primary endpoint was overall survival. The secondary endpoint was progression-free survival and objective response rate. To achieve a power of 80, with the assumption of the median OS for 4 months for the control group, a total sample size of 74 subjects with 70 death events is required. Therefore, an enrollment of 84 subjects was planned, allowing for a 10% dropout. From July 2018 through September 2022, a total of 98 patients screened at 84 patients treated, 43 patients were in ibrutinib group, and 41 patients were in control group. All 84 patients were in ITT analysis populations, and 81 patients were in FAS. At a median follow-up of 4.4 months, the two groups were generally balanced with respect to baseline features. The study was initiated prior to the World Health Organization 2021 classification, and in turn, there was a small number of glioblastoma IDH wild type included among the IDH mutation population. As of April 1st, 2023, the average follow-up was 9.9 months in the ibrutinib group and 6.8 months in the control group. The median overall survival was 6.31 months in the ibrutinib group as compared with 3.38 months in the control group. The 3-month improvement in the overall survival with ibrutinib treatment is both statistically and clinically significant. The HR value was 0.52, indicating a 48% risk of death reduction in the ibrutinib group. Since 1996, the 3 drugs approved by the FDA for the treatment of glioblastoma have improved overall survival by 1.8, 2.1, and 2.5 months, respectively. In our study, ibrutinib improves 3 months. Similar results were identified in ITT population. Looking at the secondary endpoint, the median PFS was 1.87 months in the ibrutinib group as compared with 1.05 months in the control group. PFS was significantly improved in the ibrutinib group. In the ibrutinib group, the objective response rate, ORR, was 9.5%. In the control group, it was 2.6%. The ORR number was not statistically significant, but there was a difference. This was one of the PR patients in the study. A shrinkage-enhanced lesion was observed after 2 cycles treatment of ibrutinib. In the ibrutinib group compared to the control group, there was a notable reduction in the risk of mortality observed across various subgroups, including KPS score between 60 and less than 80, age above 40 years, female gender, absence of subsequent combined anti-cancer therapy, presence of IDH mutant glioblastoma, a history of one prior anti-cancer surgery, and previous use of bevacizumab. Furthermore, when analyzing the impact of tumor size at baseline, it was found that patients with a tumor size equal or less than 3 centimeters in the ibrutinib group demonstrated a significant improvement in overall survival compared to the control. The median overall survival of patients was 32.5 months in the ibrutinib group as compared with 4.2 months in the control group. For patients with a tumor size at baseline above 3 centimeters, there was no significant overall survival difference between the ibrutinib and control groups. Ibrutinib also showed favorable safety profile. Most treatment-related adverse events are graded 1 to 2 and recoverable with clinical management. Treatment-related adverse events of grade 3 or higher severity were observed in 7% in the ibrutinib group and 12.2% in the control group. No serious treatment-related adverse events were reported in the ibrutinib group and only 2.4% in the control group. Of note, no deaths were attributed to the study treatment in either the ibrutinib group or the control group. The most commonly observed treatment-related adverse events in the ibrutinib group were rash in 25.6% of patients, peripheral edema 14%, increased levels of ALT 11.6%, and vomiting 9.3%. In the control group, the most common treatment-related adverse events were vomiting in 29.3%, nausea 17.1%, decreased white blood cell count, and constipation 14.6%. In summary, the FUSION study resulted in a statistical and clinical improvement in overall survival and PFS in patients diagnosed with IDH mutant high-grade glioma bearing CM fusion. When compared to the control group, these findings highlighted the substantial and meaningful therapeutic benefits of ibrutinib, supporting its potential as an effective treatment option for a subset of IDH mutant high-grade glioma. FUSION trial sheds light on a novel therapeutic pathway in the landscape of IDH mutant high-grade glioma. In April 2024, ibrutinib has received the full approval by NMPA in China for the adult patients with astrocytoma IDH mutant World Health Organization grade 4 with a ZM fusion or glioblastoma with low-grade glioma history who have experienced treatment failure in prior therapies. At last, I would like to talk about why we call this trial as FUSION. FUSION is one of the two major Pu Xian Pu Sa. We call it in Chinese, represents Vision Act. In China, people think doctor is like a Pu Xian Pu Sa that gives people health body using the combination of practical spirit and lofty ideals. Clinical work only uses practical spirit to cure patients, but clinical trial combined with the practical spirit and lofty ideals to treat more patients. We know we cannot cure every glioma patient, but curing glioma seems like Noah's Ark. What we want to do is more research and our best to give boarding tickets to more patients who want to board on the Ark. Cutting-edge research, technology and therapies, cure for CNS tumor patients. Joint consultation. Dedicated to providing cutting-edge glioma research, technology and therapies, cure for gliomas and other central nervous system tumors, relying on the expertise of academician Tao Jiang's team at the Beijing Tiantan Hospital. Our multidisciplinary diagnosis and treatment (MDT) clinic is composed of leading physicians from neurosurgery, neuro-oncology, and other specialties. We integrate various cutting-edge treatment methods, including unique domestic and internationally advanced targeted therapies, tumor treating Files therapy, and our self-developed TRIS CAR-T, along with other comprehensive treatment plans. Our clinic offers comprehensive support and consultation, as well as personalized treatment assessments and plan development, promoting the application of the latest therapeutic technologies with the aim of improving patient survival rates and quality of life.
Doctors and Joint Consultation 桃江、保师城、小汇人、赵石宝。Clinic date every Tuesday morning. Clinic location: second floor International Department, Zone B, Beijing Tiantan Hospital. Address: number 119 South 4th Ring West Road, Fengtai District, Beijing, PR, China.